A'udhu billahi minash shaitanir rajeem. Bismillahir rahmanir rahim. Today we are going to start the disorder of hematology, and first of all we will discuss the general topic, that is the anemia. It is defined according to WHO. Anemia should be considered to exist in adults whose hemoglobin levels are lower than 13 gram per deciliter in male and 12 gram per deciliter in female. Classification of anemia. It is classified into number one, reduced red cell production, number two, increased rate of red cell destruction, and number three is the loss of red cell from the circulation. Number one, reduced red cell production. It is further classified into defective precursor cell proliferation, defective precursor cell maturation, and defective proliferation and maturation. Number two, increased rate of red cell destruction, that is called the hemolysis. And number three is the loss of red cells from the circulation, that is the bleeding. So we will discuss now the defective red cell, reduced red cells production, that is the defective precursor cell maturation. The etiology includes iron deficiency, anemia of chronic disorders like malignancy, connective tissue disorders, infections. Decreased erythropoietin production, that occurs in case of CRF, renal diseases, and decreased oxygen requirement, for example, in case of hypothyroidism and hypopituitarism. Then is the primary diseases of the bone marrow like aplastic anemia, pure red cells, hypoplasia, infiltration of the diseases like leukemia, lymphoma, secondary carcinoma, and myelofibrosis. So these are the etiologies of the defective precursor cells maturation. Then is the uh, defective precursor cells maturation. Defective precursor cell maturation result is due to number one, a defective nuclear maturation, and the causes include vitamin B12 deficiency, folic acid deficiency, and erythroleukemia. Defective precursor cell maturation also occurs due to defect in the cytoplasmic maturation, and the etiology include iron deficiency, disorder of globin synthesis, disorder of porphyrin metabolism, disorder of hemoglobin and iron metabolism. Similarly, defective precursor cell maturation also occur due to some unknown mechanism, and the etiology includes congenital dyserythropoietic anemia, myelodysplastic syndrome, infection, toxins, and uh, chemicals. Then is the increased rate of red blood cells destruction, that is called the hemolysis. Hemolysis is determined or can be genetically, and it can be due to the acquired disorders. So genetically defect disorders, these include the membrane defects involving structure and the metabolism, hemoglobin disorders, or enzymes deficiency. So there can be a membranopathy, hemoglobinopathy, or enzymopathy genetically that leads to hemolysis. And the acquired, these include autoimmune disorders and the non-autoimmune. Non-autoimmune disorders are the trauma, membrane defect. These are drugs, chemicals, toxins, bacteria, parasites, and hypersplenism that leads to hemolysis. So these are the causes of hemolysis, that is the increased rate of RBC's destruction. Then the clinical features. Features of acute anemia, and the acute anemia results due to rapid blood loss from the body. And the features are number one, syndrome of shock with collapse. Number two, patient has dyspnea. Patient will have increased heart rate, that is the tachycardia, poor volume pulse, and decreased blood pressure. Similarly, at the same time, patient may have marked peripheral vasoconstriction. So these are the features with when the patient has a acute rapid blood loss from the body leading to anemia. Then are the features of the insidious onset of anemia. In this case, the anemia can be mild or it can be moderate to severe. So, in case of mild anemia, either the patient is asymptomatic or has simply increased fatigue or slight pallor. While in case of marked to severe anemia, the following signs and the symptoms may occur. The important one are the cardiovascular signs and the symptoms. These include exertional dyspnea, increased heart rate, that is the tachycardia, palpitation, that is the self-awareness of the heartbeat, angina, claudication, night cramps, increased arterial pulsations, cardiac roots, reversible cardiac enlargement, signs of heart failure. These include the basal crepitation, peripheral edema, and ascites. So, it's the only cardiomegaly that get reversed, and it's due to anemia. When we will correct the anemia, the cardiomegaly will be corrected. The size of the heart will become normal. So important sign in case of anemia is the pallor, and the pallor we check on in the mucous membranes, nail pad, and the palmar creases. Other features include neurovascular signs and symptoms, and these are headache, vertigo, lightheadedness, faintness, tinnitus, roaring in ears, cramps, increased cold sensitivity, hemorrhage in retina. Papilledema and occasionally can be seen occasionally in case of acute anemia. GIT signs and the symptoms, these include loss of appetite, nausea, constipation, and diarrhea. Similarly, genitourinary signs and symptoms, which may include menstrual irregularity in females, urinary frequency, and loss of libido. And then at times the patient may have low-grade fever. So these are the features of anemia. Now, how will you investigate? What are the basic investigation for the anemia? The important one is the blood complete examination or the complete blood count, in which we will see the hemoglobin concentration, TLC, DLC, reticulocyte count, and platelets. Sorry. Here is the report. When we advise the patient to have a CPC, so the patient bring back a report of CPC. So here we can see this is the WBCs. This is the WBC count of patient, and this is the normal range. So normal range can be 4.5 to 10.5. While studying the CBC, we first look at the WBC count, then we will look at the RBCs count, and the hemoglobin, then at the platelet count. These are the three series of the cells in the blood. So WBC count, it's a normal within normal range. When we see the RBCs, so the patient is having 5.73 into 10 raised power 6 units per liter, and the range is 5 to 6. And when the patient is having 15 hemoglobin, that is the 15 gram per deciliter, and the normal range is 11 to 18 grams per deciliter. Similarly, platelets, patient is having 246 into 10 raised power 3 microliter, and normal range is 150 to 450. So this is the actually normal report of a patient. Uh, and in case of anemia, what will happen and what we will see actually, we will see the RBCs that will be less than 4 into 10 raised power 6 microliter. And then we look at the hemoglobin, it will be less than 11 gram per deciliter. And when we see at the MCV hematocrit, sorry, the hematocrit will also be decreased. That will be less than 37%. Then to categorize which type of anemia the patient is having, we will look at the MCV, that is the mean corpuscular volume. And that is, if it is less, then we will label it as a hypochromia, that the volume of the size is the volume of this or the size of the RBCs is less, they are decreased. And then we will see the MCH, that is the mean corpuscular hemoglobin, and that shows the hemoglobin level in the RBCs. And if it is less than 27, we will say it's a hypochromia. So on the basis of the hemoglobin, we will label that the patient is anemia, and on the basis of the MCV and the MCH, we classify anemia into three, four types. So peripheral blood film. What will we see on the peripheral blood cells? We see the MCV, okay, what is the size of the RBCs, what is the shape of the RBCs. If the size of the RBCs is variable, here is the normal size, usually they are of the same volume. So when the patient peripheral smear shows the RBCs volume or the size is variable, it is called an asocytosis. And if the shape of the RBCs is variable, so it is called poikilocytosis. When the size is variable, it is called an asocytosis. When the shape of the RBCs is variable, it is called achelocytosis. So these are the RBCs, and these looks to be a normal. The size, volume, and the size is of same, and the pigment is also the normal one in the these patients. Yeah. And this is the lymphocyte, blue one, with large nucleus, less cytoplasm, and this is the neutrophil. Neutrophil has segmented nucleus. So this is the normal picture. But when the patient has different values of MCV and the MCH, we divide the peripheral film into um, 4 or 5 types of anemia. That is the hypochromic microcytic anemia, normochromic macrocytic anemia, polychromatophilic macrocytic anemia, normochromic normocytic anemia, and leukoerythroblastic anemia. We discuss one by one these three types and their etiology. In a hypochromic macrocytic anemia, means that this hemoglobin is less and the size is also, the volume is also decreased. So there will be a decreased MCV, mean corpuscular volume, and there will be a decreased MCH, that is a mean corpuscular hemoglobin. So there are three causes of macrocytic hypochromic, hypochromic macrocytic anemia. These are the iron deficiency anemia, thalassemia, and sideroblastic anemia. Then is the normochromic macrocytic anemia, means that the size of the disease or the MCV is in this macrocytic, mean the size of the volume of the RBCs is increased. That is the MCV, that mean corpuscular rate is increased. But the MCH, that is the mean corpuscular hemoglobin, that will be of normal. So patient will be labeled as a macrocytic normochromic or normochromic macrocytic anemia. And the causes include vitamin B12, folic acid deficiency, and alcohol and myelodysplastic syndrome. Then is the polychromatophilic macrocytic. In this case, the patient RBCs have increased MCV, that is the mean corpuscular volume. That means that the size of the volume of the RBCs will be increased, like megaloblastic anemia. But we will see that there is a polychromatophilic, means that in the color and the stain will be of a different colors. So it is due to hemolysis. When there is a hemolysis, increased breakdown of RBCs, the patient will have a polychromatophilic macrocytic anemia. The, then is the normochromic normocytic anemia, means that the MCV and the MCH is of normal value, means that the size is normal and the hemoglobin concentration is also normal in this case. So, causes includes chronic disorders like infections, malignancies, connective tissue disorders, and chronic renal failure, hypothyroidism, and hypopituitarism. Pure red cell hypoplasia, aplastic anemia, primary diseases of the bone marrow. So these all are the causes of normocytic normoglobic anemia. Then is the leukoerythroblastic anemia, in which the indices usually are normal, but the leukocyte and the RBCs are of immature type and they are large in size. And the causes includes myelosclerosis, leukemias, and the metastatic carcinomas. So this is the classification of anemia on the basis of a peripheral smear examination or on the basis of the MCV and the MCH. Now, how will we manage the case of anemia? Generally, first of all, we have to look for the cause of the anemia and then we start the treatment accordingly. Um, how to investigate further? It depends upon what is the MCV and the MCH of the patient. If the we have discussed if the MCV and the MCH is decreased, so it will be a macrocytic hypochromic anemia, and the causes are iron deficiency, vitamin B12 deficiency, and folic acid deficiency. Iron deficiency, thalassemia, and the sideroblastic anemia. These are the three causes of the hypochromic macrocytic anemia. So further, we will investigate to see okay, there is a deficiency of iron, or there is a thalassemia, or there is a sideroblastic anemia. So we will advise the iron deficiencies in this iron studies. We will advise the electrophoresis of for the hemoglobin, and we will go for the detailed peripheral smear examination to see the sideroblast on the microscopy. Then, if the patient has suppose the reports came with disturbed iron studies, means that the serum iron is less, ferritin is decreased, percent saturation is increased. So we will label okay, this have macrocytic hypochromic anemia is due to iron deficiency. So we will give the replacement of the iron. So we treat means that we treat the anemia according to the underlying cause. So first of all, we will determine or sort what is the cause of anemia, and then when we start the treatment. But at times, the patient is not actually. It is very important. At times, the doctors treat the anemia just by giving the multivitamins. So it's not the way to treat anemia. Best is to see the underlying cause. However, if the patient is not affording or it is difficult to further investigate and the history is clear about the iron deficiency, for an example, a patient is taking less diet, a patient has a chronic blood loss, and it's a female having multiple pregnancy, frequent pregnancies. So it will show that the patient will be having iron deficiency, and we will then can start the treatment of iron therapy. Or suppose the patient has a clear history of blood loss and he is having acute anemia, then we will go for the blood transfusion in spite of further investigating the patient. And similarly, in megaloblastic anemia, we start the vitamin B12, folic acid once the diagnosis is established. So, this is the general features, general discussion on the anemia. You should keep in mind all the features which we have discussed, because we for in the next coming lectures or the next lectures we will discuss each and every type of anemia in detail, their causes, their features, their further investigations, and their managements. And while discussing all these types of anemia, so this discussion will be very helpful. So carefully study this topic, remember it, and inshallah, in the coming lectures, we will discuss the further different types of anemia. Thank you very much.